Hello and good day, everyone. This is Megan Dotson, Program Manager of the National American Indian and Alaska Native Mental Health Technology Transfer Center. I want to thank you for joining us today for our webinar series. Today we have James Ward here to present on behavioral health screening and best practices in Indian health care. This training series is brought to you by the National American Indian and Alaska Native Mental Health Technology Transfer Center. We are part of the MHTTC network, which also includes 10 regional centers, a network coordinating office, and the National Hispanic and Latino MHTTC. This project is supported by the Substance Abuse and Mental Health Services Administration. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. We would like to note that we are working to add other continuing education options for a greater number of behavioral and mental health providers, and we will announce these options as soon as they are available. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar. Please use the chat pod to share your questions and comments, and we will address these questions at appropriate points during the presentation or at the end if time allows. So our speaker today is James Ward. James Ward is an enrolled tribal member of the Choctaw Nation of Oklahoma, and he lives in Barona Reservation in California with his wife, who is an enrolled tribal member of the Barona Band of Mission Indians. James is the president and CEO of J.L. Ward Associates Incorporated, which is a consulting firm that specializes in Indian healthcare planning, development, and evaluation. He has worked with tribal and urban Indian health programs and the IHS for over 25 years in California and other states. He currently works on an IHS MSPI project, 2 SAMHSA Native Connection projects, a SAMHSA TOR project, and a SAMHSA Garrett Les Smith project. He specializes in outpatient and residential treatment system delivery, integrated care services, and behavioral health screening. So with that, I will leave it to James, and thanks for joining us. Welcome.
Thank you, Megan. I appreciate that introduction. One of the things I want to mention during this webinar is that I think they did a pretty good job of giving just a brief summary of my bio, but I wanted to also mention that I work every day with Indian health programs, just like yours, and working on developing behavioral health services, medical services, dental services. And one of the things that we're always trying to figure out is the best way that we could possibly deliver services to our patient population that will have the greatest impact and cause the greatest improvement for our community members. And so some of the projects I've been working on lately have been really focused on the development and implementation of integrated care services, meaning that we are focused on integrating behavioral health services into medical service delivery. The reason for that is because with the programs that I work with, most of our community members access the healthcare services through the medical department, and it gives us the greatest opportunity to be able to reach the largest number of people possible on a daily basis. And it's also important to mention that if you look at it from a funding perspective, there is a lot of money available in to support the development and implementation of integrated care services in our Indian Health programs. As Megan had mentioned, I currently am working with Indian Health programs on MSPI project, Native Connections project, Tribal Opioid Response project, and Garrett Lee Smith project. We're also in the process of developing a domestic violence portion of integrated care services. But there's a lot of other funding opportunities like circles of care, target capacity expansion, this expert grants, behavioral health integration initiative through Indian Health Service. There's a lot of project opportunities and a lot of money out there that could support the development of integrating behavioral health services into your medical departments. Some programs also integrate into dental as well as pharmacy and look for opportunities to integrate their behavioral health services into some of their other departments so that they can reach the largest number of people possible. The title of this talk is Behavioral Health Screening Best Practices in Indian Healthcare. So I'm going to be focused specifically on practice in Indian healthcare. I don't do work in any other area. I only work in Indian healthcare, and so this talk is going to be focused on best practices for screening purposes. During this talk, I'm going to cover a few items. The first item I'm going to talk briefly about is Indian Health Service, GIPRA standards and performance. Then I'm going to talk about a national Indian Health Service ASPE best practice evaluation that we did a few years ago, looking at best practices for behavioral health screening in our Indian healthcare programs. I'm going to share some information with you about that. And then finally, I'm going to talk about Riverside San Bernardino County Indian Health, which is one of the programs I work with here in California. And I'm going to share some information with you about work that we're doing to apply the best practices and to make dramatic improvements in expansion with our integrated care services. And specifically, we're using a new software application technology called ScreenDocs. And I just want to let you know that we develop ScreenDocs. And so we have a financial interest in investment in ScreenDocs. But we're having such tremendous success with the work that we're doing with ScreenDocs that I've been asked to specifically mention and discuss ScreenDocs with you so that you know that ScreenDocs is out there and you have it as a resource or option if you choose to develop integrated care services and electronic screening like what we're doing in Riverside. So this graph shows that our Indian health programs have been conducting behavioral health screening in our medical departments for some time now. We started reporting behavioral health screening results to the Indian Health Service for the Government Performance Results Act back in 2004 for alcohol use for women ages 15 to 44, and then also domestic violence. And then in 2006, about 2006 is when we started reporting depression screening results for Indian adults 18 years of age and older. And then you can see how we've progressed over the years to last year, 2017. We screened on a national average 66% of our target population for domestic violence, 68% of our target population for alcohol use, and 69% of our population for depression. Then if you look at this chart, this is the most current screening results for Indian Health Service, GIPRA, on the national averages. So you can see that for tobacco cessation delivery, we delivered to 28.9% on a national average, 40.9% for alcohol screens, 36% for depression for our youth ages 12 to 17, 43.3% for depression for adults 18 and older, and then 38.1% for domestic intimate partner violence. So the reason why I bring up these graphs is that you can see that on a national average, our Indian health programs are screening less than half of our patient population for these behavioral health issues. And of course, we all understand that the way that GIPRA works, and that we have some new measures here where some of the screening measures have been made to be more universal, so they're covering both male and female, and they're now also covering youth in addition to adults. So it's changed a little bit that way. And then, of course, also the way that the Indian Health Service defines a GIPRA patient also affects the number of individuals that we're able to screen and report on an annual basis. So we understand all that. But I think that this chart, and also the previous chart that shows us our performance over the last 10 plus years, shows that we as our health programs have uh, are only screening about half of our target population. I want to just mention that it's not our whole population, our whole patient population. It's just the target population. And so this is one area where we could potentially make a lot of improvement. Somebody asked me recently at a conference, why does the graph curve the way that it does? And in the previous graph that I showed you, why does it curve that way? And I thought about that, and I went back and I looked at all of the GIPRA reports over the years. And one thing that I noticed is that our health programs tend to screen our patient population according to the GIPRA definition specifically, and that our performance typically matches what our annual targets are. In some of our evaluation work that we've done across the country and in evaluating behavioral health screening in our Indian health programs, we have found that typically the health programs are screening their patients according to the Indian Health Service GIPRA definitions and methods. For example, screening patients annually or one time a year, and they tend to follow the Indian Health Service GIPRA standard as the standard. But I think that for our Indian health programs, and also as a best practice, screening patients one time per year for these issues is not the best practice. It's actually a poor practice, and it actually creates a disparity in care in the sense that we're not providing equal opportunity and access to screening and service opportunity for our entire patient population. We're only making those services available to a select few, to the individuals that we happen to just screen in that particular year, that particular time. I also want to mention too, to recognize that these are just averages. So that means that we have some programs that are screening far above the national average. We have other programs that are screening below the national average, and we have many programs that are screening at the national average. So I'm not going to generalize and say that all of our Indian health programs are performing exactly the same way with our behavioral health screening in our programs. We're all doing it a little bit different, performing a little bit different. But the point is that on a national average, we can see that there's a lot of room to make improvements with our behavioral health screening work, just based on what we're seeing from our national reports. The and the other thing I want to mention too is that a lot of us are working on tribal opioid response grant projects. Also, I'm currently working on one. And as you know, drug screen is not a national Indian Health Service GIPRA measure. In the work that we've done with evaluating health programs, we found that pretty much all the programs that we have worked with or evaluated are not screening patients in their medical departments or other departments other than their behavioral health departments for drug use. And that causes a problem for when we're trying to deliver on drug use services. And why does it matter? Because low screening rates, intervention rates are directly related to screening rates. If you have low screening rates, you're going to have low identification rates, and you're also going to have low intervention rates. So one of the ways that you can improve your intervention services, or the number of individuals that you deliver behavioral health intervention services to, is to improve your identification. And one of the ways to improve your identification is to improve your screening processes, or your behavioral health screening processes in your departments. So I'm going to talk just for a couple minutes about a national project, evaluation project that we did for the Indian Health Service and the U.S. Assistant Secretary of Planning and Evaluation. We did a national behavioral health screening best practice evaluation. And what Indian Health Service and ASPE wanted to know was, out of all of the Indian health programs in the country, including yours, out of all of the Indian health programs in the country, the ones that had the highest behavioral health screening rates in the country, the highest, what are they doing that makes them high performing compared to everyone else? So the Indian Health Service selected 16 health centers. 10 of them were, or 9 of them were Indian Health Service facilities, and 7 of them were tribal facilities across 10 states. And what we did was we conducted individual meetings with the medical department, with administration, with the behavioral health staff, and also the data entry staff. We met with them all separately. It took us 3 years to complete this project. And we wanted to learn from them what they thought were their barriers that made behavioral health screening difficult, and what they thought were their best practices that made them successful. And we also looked at a variety of other things too. We looked at their staffing, we looked at their referral resources, we looked at their referral processes, their treatment services. We looked at a whole bunch of stuff. But for the purpose of this talk, I'm just going to talk about their behavioral health screening barriers and best practices that were reported by these Indian health programs that had the highest behavioral health screening rates in the nation. I want to share with you some information that they shared with us. So the first thing I'm going to talk about is screening barriers. And when you look at these barriers, I'm going to review a few of them with you, about 6. They actually reported a large number of barriers, but I'm going to share with you the top 6 barriers. And when you look at them, these barriers aren't anything that are unique or special. These are barriers that every Indian health program that I've ever worked with encountered these exact same barriers. These are barriers that your programs have as well, I'm sure. And so these are the same barriers that these high-performing health programs had as well. The first one is they did not have enough staff to always complete the screens. So we have to remember that the behavioral health screening process typically is a manual process, and everyone does the screening process differently. We have some programs that still use paper questionnaires. Sometimes they'll have a general screening question like, do you drink alcohol or do you use alcohol? And the patient will answer just a general question like that. And if the patient answers yes to those general questions, then they'll sometimes give them a standardized tool like the cage or the audit. And then they have to interview the patient and fill out the questionnaire, and then all that information has to be hand entered into the electronic health record. Some programs have patients just fill it out themselves, and other programs have templates that are built into their electronic health record system, and the staff member interviews the patient, completes the template, and then the EHR calculates everything and reports everything. But the point is that it's a manual process. It takes a staff member to do that work. And so you can see that if you had a staff opening or vacancy, how that could become a barrier. Staff members who are on vacation or sick, or if your medical department is having an emergency, which requires staff. Those things can take staff away from their normal routines. And usually one of the first things that goes out the window is behavioral health screening. So the staffing, lack of staffing or not having enough staff to complete the screens is one of the top barriers in preventing screenings from being done successfully. The second item is staff doesn't receive enough training, and that means that they don't know what their roles and responsibilities are. They don't know whose role and responsibility it is to do the screening. They don't know what to say or how to say it. Sometimes they don't understand why the screenings are important. They don't know what the expectations are or what's expected of them. And because of that, then they become resistant to the screenings. They don't want to do the screenings because they're not really sure what to say or what to do or how to do it, and so they don't want to do it. In fact, I was at a health center recently, and one of the medical providers came up to me and said, "James, I don't understand why we're doing all this behavioral health screening in our medical departments. Mental health issues is not our problem. We don't deal with mental health problems here. We deal with medical issues. You guys go and get millions of dollars worth of grants, and then you make us do all the work." So it's just staff resistance because they don't understand why this work is important, and they don't fully understand how the work is supposed to be done. And so then they can become resistant to it. And that becomes a barrier for getting the screenings done. Lack of standardized process. One of the things we see a lot is that there's not an established routine. Uh, that sometimes the screenings are done differently by different people. You have some staff members that will ask their own questions that they made up, some staff members who use standardized tools, some people who will give the patient a questionnaire, other people who will interview the patient, some people who screen, some people who don't screen. And you can have all that happening within your same medical department or your same department or across your health centers. The screening process is extremely inconsistent. Sometimes they don't use standardized tools, as I mentioned. And then what happens is that sometimes when your screening processes are inconsistent and you don't have a routine, then patients are not used to it. And this is one of the things that we see with programs that are implementing their behavioral health screening processes according to the Indian Health Service GIPRA standards, where they screen patients once a year. So you could see how if you were to follow the Indian Health Service GIPRA standards and you're only screening 38-40% of your patient population, you could see how you could have some patients that could be coming to your health centers for years and they're never screened for anything. And then all of a sudden one day they're being asked to answer these questions, and it becomes uncomfortable to the patient, and they get suspicious. They can get suspicious, wondering why you're all of a sudden asking them these questions. I've been coming here for years and I've never been asked these questions. Why are you all of a sudden asking me these questions? And that's typically what happens when you have a behavioral health screening process that is not a routine. The patients don't know what to expect when they come in to your health center. And then also the next one is community norms often don't see the problem. We work in Indian health or Indian communities where there's a lot of stress and anxiety. Our kids are stressed out, their parents are stressed out, their aunts and uncles are stressed out, their grandparents are stressed out. And so stress and anxiety becomes normal. It's just a normal way of life. It's just the way things are. And so they don't see the stress and anxiety as being unusual or abnormal. So that becomes norm. That becomes a norm. It can become a community norm. I worked with a program once that talked about they talked about a man who used to sit under a tree every single day and he drank a case of beer. And if he wasn't sitting under the tree with his case of beer, that's when people got worried about him. So we can see in this particular case how these types of things become community norms. And when these behavioral health issues become normal, then people don't see them as a problem anymore. And that becomes a barrier to screening. Referral resources are sometimes limited. Some programs decide that, well, we don't have any referral resources, or we have limited referral resources, or our referral resources are too far away, or people don't have transportation to get there. They don't have the money to pay for the service. So we're just not going to do anything. We're just not going to do anything. We're not gonna ask the questions. We're not going to screen, because if we screen somebody and we identify a problem, then we're responsible for dealing with it. And so then they just decide not to ask the questions at all, and so that becomes a barrier. And then finally, the last one is patients don't always answer truthfully. And of course, we all understand that there's a stigma attached to behavioral health services, and also our Indian people, really all people, are private. We don't like to share our personal problems with other people. Um, Typically, we keep those things to ourselves or to our family members, but we don't like to share them outside. And and so that becomes a barrier. But then also it's an issue of trust, an issue of trust, and it's an issue of trusting staff. And so if some of our Indian Health programs, they have a really hard time with retaining their staff, having, they have staff retention issues, and they have providers who are coming and going constantly. It makes it really, really difficult for our Indian people to develop a relationship with their providers, to develop a trusting relationship with their providers, and that becomes a barrier. Also, you can see if you have staff members who are resistant to the screening, they have a bad attitude about it, like the person I mentioned earlier. Usually they communicate that some way, either verbally or non-verbally, to the patient, and then the patients pick up on that, and then they feel, well, if it's not important to the staff member, then it's not important to me either. And or you can have a situation where you have a patient who actually needs help, and they know that that staff member has a bad attitude about it, and they're resistant um, to talking to the staff member or giving truthful information. So that becomes a barrier to the screenings. One of the things I wanted to mention that these Indian health programs about these Indian health programs is that even though they experience numerous barriers for their behavioral health screening, these sites were still able to be the highest performing healthcare programs in the country. And basically, the way that they operated was that instead of being problem focused, they became solution focused. So for every problem that they encountered, they found solutions and ways to be able to deal with that particular barrier and to do the best job that they possibly could with what they had. And that helped them to be high performing. Now I'm going to share with you a few tips that they shared with us as far as best practices. And as you notice in print, it says recommendations, because the way that we approach this is if you were to make recommendations to other Indian health programs as far as what they could do to improve their behavioral health screening processes, what are the things that you think are the most important things that they could do to improve their practices? So this is their recommendations to you, and to your health programs. The very first one is require staff to screen. This is, I think, probably one of the most important items on this list. Basically, if staff members, if your program does not make behavioral health screening a requirement, then staff members perceive behavioral health screening as being an option. They perceive it as being an option. And so the way that you improve your behavioral health screening practices is that you make behavioral health screening required. And so how do you do that? Well, it starts from the very top of your programs. It has to start with your tribal council or your board of directors, down to your administration, down to your department directors, and then down to the staff. And it has to become a requirement. It has to be expected of your staff members. Every single day that has to be communicated. They have to understand that screening our patient population for these behavioral health issues is important. It's a priority, and it's a requirement. It's something that we have to do with our patients every single day. The second item is to standardize the screening process. That is to find ways to use the same screening tools, preferably standardized tools, use the exact same process, use the same process with all staff members across all departments, across all health centers. And of course, one of the best ways to establish that is through creating policies and procedures that explains when screenings are to be done, where they're to be done, how they're to be done, and who's supposed to do the screening. So it's very, very clear how that screening process is supposed to work. And it also gives you an opportunity to establish a set routine and to establish responsibilities and also accountability with your staff members within your health organization. And then, of course, train staff on the screening procedures. Once you have established your standardized process, then you want to make sure that your staff members understand the process and who's supposed to do what. And so you need to train your staff members on that particular process. The next one was screen all patients during each visit. So the high performing sites use universal screening procedures. They did not follow the Indian Health Service standard or definition at all. The Indian Health Service standard, I understand why we have the Indian Health Service GIPRA measures, but in my opinion, based on what I've seen with working with programs, these high performing programs, is that the Indian Health Service should be our minimum standard. It should not be the standard. It should be the minimum standard. And the evidence-based practice for screening is universal screening, and that's what these high-performing sites did. So they found ways to screen their patients during each visit. They usually screen their patients during the vital or triage routine. They made it part of that routine. It didn't matter the reason why they came in for their visit. They screened all patients, no matter the purpose of the visit. And as I just mentioned, they even screened those individuals who were not part of the GIPRA population. They just screened everybody. They screened even if referral resources were not available. And I've had people ask me questions about, well, what do you do if you don't have referral resources available to you? And that's an issue that has to be discussed by each individual health program, but there are opportunities to even train your medical staff and being able to provide some brief intervention, education, and support so that you could potentially provide something versus nothing. And then also to improve staff communication. I think this is a really important one too, because I tend to find out that a lot of our programs, their staff members work in silos. They don't necessarily work together or interact with each other or communicate very well. And so and it's not just about communicating, it's about actually working together as a patient care team, providing wraparound type services around a patient. So these programs found opportunities to do that. They had joint staff meetings. They would do joint trainings. They created patient care teams that involved both medical staff, behavioral health staff, as well as other staff members as part of a care team. And they also created committees where they got people together and they all work together. I'm working on a project right now where we developed an integrated care committee, and we have staff members from administration, from IT, from our GIPRA coordinator, panel manager, pharmacy, medical, behavioral health, just a variety of people, quality control, quality management, just a variety of people. We meet once a month and we work all together as a group on our integrated care services. And that seems to be very, very effective, because what happens a lot of times is that when you need to get things done, and you're relying on your IT department to do something, chances are it doesn't always get done. But then when you have a committee like this, where there are problems discussed and there are assignments made to individuals, then the next committee meeting, the expectation is that those particular items on the agenda were taken care of, and then we're able to move on to the next item. So it does provide a sort of an opportunity for staff accountability, and it also creates some good positive peer pressure also, because you can have some individuals on the committee who are not quite sure about integrated care services or behavioral health screening. Some people are completely in support of it, but over time what happens is everyone starts to work together, and you'll see some of the people who are a little bit resistant becoming more supportive. And so it creates a really, really nice opportunity to develop that support and working arrangement. So one participant from one of the organizations that we evaluated said, we screen everyone because you never know when you're going to hit somebody that has problems. Domestic violence or alcohol, or even all three screenings, it is a respect of no person or status. It doesn't matter if you have a diamond necklace or if you have an old ragged t-shirt, you're going to get screened. Again, the point is that they screen everybody. And this is a really, really important statement because sometimes our providers think, oh, I've known that person for years. I've known them for years. They're fine. They don't need to be screened. But the truth is that they don't know always what a person is thinking or how they're feeling. In fact, there was a study that was done where they looked at the interactions between medical providers and patients in regard to behavioral health problems. And so what they did was they had evaluators actually sit uh, in a room with a medical staff member that was treating the patient, and the majority of the time that a patient would bring up a depressive symptom or some sort of behavioral health symptom, the majority of the time the medical provider would change the subject to something that was related to a physical problem. And then they found that typically a patient would bring up the symptom or problem again a second time, and the provider would change the subject and would ignore what the patient was saying. So I think that if we have any medical providers on the webinar today, my challenge to you, a recommendation to you, is to pay attention to your patients and what they're saying to you. Specifically, pay attention to if they mention any types of behavioral health symptoms or problems, and take the time to discuss that and explore that with the patient because it matters. It's very, very important. It's a very important opportunity. But also, the lesson here is that we can't always rely on our medical providers to be the sole source of identification of behavioral health issues. And we all have to acknowledge and understand that in the medical department settings specifically, that there is a limited amount of time and a limited amount of opportunity to deliver medical services. And sometimes these behavioral health issues could take up a lot of time. So medical staff members sometimes are pressured to stay focused on dealing with the medical issues and not getting too wrapped up in other issues that could be time consuming or that could cause a delay in their schedule. And so that's something that we have to be very aware of. And then whenever we're doing work in the primary care medical department setting, the work that we have to do has to be very brief. It has to be a brief work. So it has to be very organized and coordinated, has to be planned. Everybody has to understand exactly what they're doing so that we don't waste time, and we don't waste the time of our staff members and waste the time of our patients. But the behavioral health screening in this particular case basically helps our providers. It gives us an opportunity to identify a problem that can be brought to the attention of the provider. Or if you have an integrated care staff member, like a behavioral health staff member who's working in your medical department who can see that patient, it gives us the opportunity to take the full responsibility off of our medical providers for being the sole source of identifiers. It provides assistance to them. So that's an important opportunity there. So now I'm going to explain to you briefly just some of the benefits to using the best practices that the program has reported to us. As I mentioned, they talked about using universal screening, meaning that they screen every patient regardless of their age, regardless of their gender, regardless of their race or ethnicity, regardless of the purpose of the visit. They just screened everyone who came in. And one of the things that they said was that it's easier to do it that way. It's easier to keep track of. Some of our programs, they do a lot of work in just trying to keep track of which patients are GIPRA patients, which patients need to be screened. Recognize that some of our electronic health record systems have alert systems to alert when certain things need to be done. But they found that it's just easier to screen everyone. Every single patient just is part of the normal routine. The second one is that staff grow more comfortable with the questions and competency increases over time. So obviously, the more that staff do the screenings, the faster they get at it, the more comfortable they are with it, and they become more competent and more confident over time with the work that they're doing. And then also patients grow accustomed to being screened. They come to understand that the screening process is a normal process. It's just like the vital routine. when we go in for a medical appointment, uh, all of us uh, go through the vital routine. One of the first things that we do when we're taken back to the medical department is we have our blood pressure taken, we may have our weight done, and none of us ever question why do we do that. The reason is because we've all probably have been doing that our entire lives, and so it's something that's normal to us. It's something that is a routine, and that's what happens with behavioral health screening. When you do your behavioral health screening on a regular routine basis, it becomes normal. It becomes a normal process, and patients start to understand that that is just what they do here. They screen everyone. They screen everybody every visit. It's just what they do here, and it becomes a normal process, and the patients grow more accustomed and more comfortable with it. One thing I want to mention here is that a lot of times I'll hear from providers, well, what do we do if patients are complaining? One of the things that we have found, and one of the things that the health programs that we evaluated reported, is that when the more that you screen, the less complaints that you get. Normally, when I work with providers, they think the opposite. Well, we had a patient complain, so we need to screen less. Actually, it works the other way around. You need to screen more. If you have a lot of patient complaints, there's a good chance that your screening processes are not consistent enough, are not routine enough, and you need to improve that. When you make it more of a routine, then patients tend to get used to it, and they become more comfortable with it, and you'll have less complaints. Okay, patients don't feel singled out. I um, mentioned this just a second ago that basically they understand that programs that universally screen everyone. They screen everybody. They screen every visit. They're not asking this question to this individual because there's some suspicion. It's just something that they do with everyone as part of the routine. So then patients tend to get a little bit more comfortable with it. The second one is that screening at each visit increases the chances of identifying people with problems. The programs that we evaluated stated that sometimes it takes up to 6 screenings before a person admits the truth. It takes up to 6 screenings. So you can imagine that if you're applying the Indian Health Service GIPRA standard of screening 1 time per year, and you're only screening 38% of your target population, you may never get a truthful answer from some individuals because you're not screening frequently enough to give them the opportunity to report something to you. And so universal screening every visit if you can, is an important opportunity to give individuals as many chances as possible to report something. Sometimes it takes people time to be ready to reveal something that's really personal and intimate to other people. But by providing routine screening, you're giving them as many opportunities as they need uh, to report that. And then finally, people's circumstances change, and I think this is an important one because all of our lives can change in a second. Um, you can have a person who has the perfect life, the perfect family, perfect everything, and the next day they experience a tragedy in their life, and then their emotional state and their mental health state changes, and because their circumstances change. Or you can have an individual who's in a violent situation, an abuse or domestic violence situation, and they come into the medical department for services, and they're not able to report at that moment because the person who's the abuser is with them, and so it's a safety risk for them to be able to say anything. But the programs that we evaluated reported that because when they universally screen, patients learn that screening is done on a regular routine basis, and they reported that they had patients in this particular situation that have come in to the health center and without the abuser and taken the opportunity to do the screening and to report the problem. And by doing that screening, it gave that patient the opportunity to report that problem and to get help. And so doing the screening is a very important opportunity, and doing routine, regular, universal screening is an important opportunity because again, people's circumstances change. And then also it's important to understand that our health a lot of our community members see the health center as being a safe place to get help. And so by doing the screenings in our medical departments, especially with our medical staff members, it creates a safe place for patients to be able to report that problem and to be able to get help. But not only do we screen, we have to take the opportunity to actually look at the screening results and to deliver that service to our patient population. Okay, now I want to just take a couple minutes and share with you some information about a project that I'm working on in Riverside, San Bernardino County Indian Health, which is the uh, largest Indian health program in California. Riverside San Bernardino County Indian Health is located in San Bernardino County and Riverside County. San Bernardino County is that real large area there. It happens to be the largest county in the United States. And they have about 86,351 American Indian Alaska Native people in their service area. They have 33,817 registered patients, and they deliver services to 9 federally recognized tribes through seven health centers. And one of the things I want to mention about their health centers is that some of their health centers are larger, some of their health centers are smaller. They have some health centers that are in some more metropolitan, like urban type areas, and then some of their health centers are in uh, more rural areas where they have some of the same types of issues that everyone else has with trying to hire staff, travel distance issues, referral resource issues around some of their communities. So they're a really good example, a good representation, I think, of a lot of our Indian health programs throughout the country. The other thing I want to mention too is that Riverside San Bernardino County Indian Health has been operating for 50 years, so they've been around for a long time, and they were established by the tribes in their service area. So the tribes representatives are part of their governing body. In California, we have a lot of consortium health centers where we have groups of tribes that make up a healthcare consortium. So this is a typical thing. Is the way that our health programs, Indian health programs, are organized in California. So one of the first things that we did was we established our integrated care policies and procedures. And I want to just take a minute and just share with you our screening policy with you. Um, Basically, it states that all medical department patients, regardless of gender identity, sexual orientation, race, or ethnicity, insurance coverage, purpose of the visit, or physical and mental disability, will be screened for behavioral health problems according to the following pre-established parameters and settings at every visit during the vital routine using Screen Docs. I'm going to share with you a little bit about Screen Docs in a minute. But from this chart here, you can see that we screen our patients 1 time per year for tobacco use. We screen our patients quarterly for alcohol use. We also added the DAS-10 to do drug screening. Even though drug screening is not a GIPRA measure, we decided to go ahead and to do drug screening of our patient population in our medical departments. Um, we have a tribal opioid response project that we're working on. And so, doing drug screening helps us to identify the most people possible that have illicit drug use issues. And then we're also able to identify the patients that have opioid issues so that we know which ones need to go into our MAT services potentially. We screen every visit for depression, every visit for suicidal ideation, and every visit for domestic intimate partner violence. These are life-threatening issues. And at this moment, we're screening on patients aged 12 years of age and older. The reason why we're doing that is because in California, a youth 12 years of age and older can receive mental health services without the consent of their parent. If you screen younger than 12, you have to have the parents' consent in order to do these behavioral health screenings. So at this moment, we're screening ages 12 and older. but we're screening all patients, as it says in the policy, all ethnicities, non-natives as well as natives, in all genders. This policy goes on to explain a procedure and how that's done, but for the purpose of this talk, I'm just going to share with you our screening policy. Okay, well, I prepared a video for you that talks a little bit about screen docs and the staff's experience in doing electronic screening and how it benefits the health organization and doing electronic screening. But we're having some issues with displaying the video through Adobe Connect. So if you look in the chat box, you're going to see that there's a YouTube link there. And what we'd like for you to do at this moment is if you could go over to YouTube and click on this link, and the video is about 8 minutes long. If you could watch the YouTube video, we'll give you about 8 minutes to watch it, and then we're going to come back to this webinar, and I'm going to finish up. this presentation. The other thing I want to mention too is that just for future use or later use, this video is also on our Screen Docs website, screendocs.com. We have a section for user experience where we talk about our work that we're doing with Riverside, San Bernardino County Indian Health. You can see some of their prevalence rates. We have this video on there. So in the future, later on, if you want to look at it or share it with other people, you can go to the Screen Docs website, and under user experience, you'll be able to see some of the information I'm presenting to you today, as well as this video. So I think they're gonna. So if you want to go ahead and go to that link, and we'll give you about 8 minutes. Well, it's 10:51, so let's just say at 11 o'clock we'll come back to the webinar. Okay, so we're going to come back to the webinar. Hopefully you were able to see, hope you were able to see the video. I see that there was an individual that was having a difficult time with loading the video. But as I mentioned, if you weren't able to see it for some reason or another, if you go to the ScreenDocs website under user experience, you'll be able to see that video. You can click on it and you can watch it. Or you can also find that video on YouTube. If you search Screen Docs on YouTube, you'll see that video come up on YouTube as well, and you can watch it. And it's a nice video because it shows the how the health program feels about the screening work that we've been doing, how it's benefited them, and also one of the things that one of our tribal leaders mentioned at the very end of the video, Teresa Sanchez, is that it gives our Native people an opportunity to communicate. Sometimes our Indian people don't like to communicate things like this. They like to keep those types of things to themselves. And it gives them an opportunity and a way to communicate with without having to communicate, if that makes sense, because it's all done electronically. I think, let's see here. So I meant to include another slide, but I'll go ahead and just talk about the slide that I didn't include. And so essentially, if you weren't able to watch the video, essentially what ScreenDocs is it's an electronic behavioral health screening application that we created to help to um, get rid of the barriers, screening barriers that I mentioned earlier, and to apply the best practices. And so essentially what happens is when a patient comes in for their medical appointment, um, they go through their vital routine and then they are given a touchscreen tablet, or we also have some stationary kiosks, and the software application takes them through the screening process electronically, and we're able to apply the screening procedures exactly as the way that I had mentioned earlier, where we can set the software to screen uh, patients one time per year for tobacco use, quarterly for alcohol and drug use, every visit for depression, suicidal ideation, and domestic violence. And the software application knows those settings. So if you had a patient who came in for the first time for the year, the application is going to ask the patient, is going to screen them for all of those items. But if you have a patient who comes in the next day for a follow up, or you have a patient who comes in for chronic issues, it's not going to screen them for the annual item or the quarterly item, but it will screen them for the every visit item. So it reduces dramatically the amount and number of screenings that are done with your patient population. And of course, some people say, well, we have patients who are chronic patients who come in a lot for services. And um, what we have found is that those are some of the people that are at high risk for the items that need to be screened more regularly. So it provides an important opportunity to just keep track of what's going on with those particular patients as well. Doing electronic screening provides several benefits. The first is that you can screen every patient as frequently as needed without dependence on staff. It doesn't require staff members to do the screening because the software application does it for you. It tracks which patients need to be screened. So in ScreenDocs, you can set the screening minimum age to whatever minimum age you want. We have it set to age 12, but if you wanted to screen younger for any of those individual items, you can set the minimum age for each item and it will screen according to that setting. And then you can also change the frequencies too. So if you decided that you wanted to screen at different frequencies for each of those behavioral health problems, you could change the frequencies and the software will screen people according to those particular frequencies. The other thing is that we created this specifically for Indian health programs. So we use the Indian Health Service GIPRA standards as um, uh, part of our standard for creating it. So for example, the default calendar in the software application is the GIPRA year. So the software understands that on October 1st is when the new year starts and it ends on September 30th. So on October 1st, if a patient comes in on October 1st, it will screen them for everything, and then their screenings will get less throughout the year if your frequencies are set to similar to what I shared with you earlier. The reason why we did that was because we want to use our Indian Health Service GIPR performance report as a way of being able to measure our performance and our progress. And we are expecting to see our GIPR performance to be some of the highest performance in the state of California as a result of the universal screening work that we're doing. And then also, it scores your standardized tools for you, so you don't have to score them, and it develops a behavioral health screening report that shows you how the patient answered each individual question and the score, what the score indicates, and also the recommended treatment action that's based on what the developer of the tool recommends for that particular score. ScreenDocs also exports results electronically, automatically right now to the electronic health record for the RPMS and to NextGen. So if you're an RPMS site and you use a system like ScreenDocs will, as soon as the patient is done with the screening, it automatically exports those results to the patient's health record. So it's available in the health record real time for the patient, for the medical provider to deliver services, or for the behavioral health provider, medical provider to deliver services to the patient real time during that visit. And of course, it standardizes the screening process across all departments and health centers, so that patients are being screened exactly the same way across every department, every time they come in, at every location. And this is one that I think is really, really important, is that it provides real-time patient information in prevalence rate reports. And this is an area where we see a lot of our Indian health programs have a lot of problems, is with our data. Of course, we put a lot of information into our electronic health records, and then when it's time to try to pull that information out and make sense out of it, it's really, really difficult to do. And a lot of the Indian health programs that I've worked with tend to rely on national household survey data, county data, data that's collected by universities, as data to support needs for particular services or funding in their community. And what's happening in Massachusetts may not necessarily be relevant to what's happening in Hoopa, California. But we try to use that information to support and to support the need for certain services in our particular community. The nice thing about doing screening like this is that every time that we screen a patient through this system, that information goes into a database, and that database has dashboard reports. And so real time, every day, all day long, the dashboard reports are calculating the number of individuals that have been screened, the number of individuals that have positive or negative results, screening results by problem, and then also it reports it by severity level. So we know the exact number of patients that screen positive for moderate depression versus severe depression. We know the exact number of patients that screen positive for the 3 different levels of suicidal ideation. And then ScreenDocs also reports that information by age groupings. So we know the exact number of patients by whatever age group that we tell ScreenDocs to show us. We know the exact number of patients that screen positive for those problems. And we can also see that information by individual health center locations. So if you're an organization that has multiple health centers, we can see that information by multiple health center location, which represents the individual communities that they're serving. So what I'm going to do is I'm going to take a couple minutes, and I'm just going to show you some of our prevalence information. So far we've completed 38,580 screens for 15,768 unique patients. So we have quite a bit of experience with doing the screening at Riverside. So far, 4,254 individuals So 26.9% of our patient population is screened positive for depressive symptoms. That's a depression. That's a PHQ-9 of mild to severe. Of those, 2,218 patients, or 14%, screened positive for depression with a PHQ-9 score of 10 or higher. It's my understanding from what I've seen so far that the national average for depression screening or depression result with a PHQ-9 score of 10 or higher is about 6.4%. So our patient average is more than double the national average as far as for depression. And so currently we're really focused on our depression and our depression issues and depressive symptom issues with our patients, and we're focusing a lot of our time and a lot of our funding resources and grant money on dealing with depression and suicidal ideation issues. We've had 791 patients screened positive for suicidal ideation. That's a lot of people. And if you talk to any of the healthcare staff, they'll tell you that a good portion of these people would have been missed in the past. But the fact that we're doing universal screening electronically has helped us to identify more people and to be able to help more people as a result of that. And then we've had 230 individuals screened positive for domestic intimate partner violence. We've had over 1,000 people actually tell us that there's some level of abuse or violence in their lives, but 230 actually screened positive with the standardized tool. And then we have 1,663 individuals screened positive for an alcohol problem. This is not just alcohol use, this is an actual alcohol problem. And then in October 1st, we started drug screening because of our Tribal Opioid Response Project. And we started drug screening with the DAS-10. And so far, we've completed 6,090. We've screened 6,090 individuals. And of those, 436 patients screened positive for, well, it says depression drug use problem. Actually, it should say positive drug use problem. So I have a little typo there. But so far, we've identified 436 individuals. So one of the things I just want to mention again is that the data that we're able to obtain from this is very, very, very useful to us, not only for being able to justify the need for funding to be able to deliver services to our patients, but then when we're working on our funding projects or grant projects, it gives us the data that we need to be able to report to our funders. In fact, we just had a visit from our SAMHSA project officer yesterday. And she told us that one of her objectives was to come to the health center to see if we were actually doing what we said we were doing in our reports, because our report numbers are so high compared to all the other projects across the country that they wanted to verify that was correct, that those numbers were correct, that we were able to actually do what we said we were doing. And so she was blown away by what we're able to achieve and a lot of it has to do with all of the things that I've mentioned in this presentation to you, applying the best practices, and then also using being able to do all this stuff electronically saves a lot of time and helps us to create a good routine. So that's the end of my presentation. I hope I gave you some good information. I hope that this information was useful to you. If you have any questions at all about anything that I presented, this is my contact information. Again, my name is James Ward. We have a website at jlwardassociates.com, and then my email address is james@jlwardassociates.com. My phone number 619-249-6641. That's my cell number. Please feel free to call me anytime if you have any questions about my presentation, any questions about the work that we're doing in Riverside, any questions about Screen Docs. Please feel free to contact me at any time. And then we also put together a website for screendocs.com, and there's a lot of information on screendocs.com. And like I said, the video is there, and there's some illustrations of the screening, the way that the screenings are conducted, and reports and things like that, and also information about features. Please feel free to go to screendocs.com and take a look at what we're doing there. And then also you can also reach us through screendocs.com too. So I want to thank everyone for your time. I know everybody's busy. Thank you for your time and for sharing and for listening to my presentation. And I hope everyone has a nice day.
Thank you so much, James, and so exciting to hear the work that you are doing. And yeah, just appreciate you sharing that with us and encouraging more screening to take place. So we'll finish up here in just a second, but before we do, I just want to remind everyone that we are recording this, and so if you wanted to share this presentation with colleagues or view it again, you will get an email with the link to the recording as well as handouts of the slides, and you'll also get a link to the GIPRA evaluation, which we're going to ask you to fill out. So in just a moment when we close out, you should be redirected to that, but if not, just watch